Good morning and or afternoon to everyone. Thank you so much for joining today. My name is Jennifer Yost and I am affiliated with McMaster University School of Nursing and Health Evidence. I am the current co-PI on a study supporting evidence-informed public health decision-making and cancer prevention, which may have brought some of you to our webinar today. And we do also welcome users of health evidence to our webinar today as well. So today we will be talking about systematic review evidence on reducing saturated fat intake for cardiovascular disease. So we would just like to draw your attention to the fact that we're going to be asking you a few polling questions to gather some information that will be useful to our presenter today, and also to give us some idea about who's joining us and your knowledge of systematic review evidence and what you may be doing with the evidence or think about doing with the evidence following today's session. So after today, just to let everyone know that the PowerPoint slides will be posted on our SlideShare account, and the audio recording will be posted on our YouTube account, both in English. And today, we're very excited to have Dr. Lee Hooper with us today, and she will be talking about her Cochrane review on the reduction of saturated fat intake with cardiovascular disease. And you will see that we will be posting links within the chat section to the actual systematic review itself, as well as the evidence summary that is available from our website at Health Evidence. So our first polling question, again, as I mentioned, we'd like to get a sense of where everyone is from. And so if you could just let us know what sector you're from, public health, a health practitioner, other, education, research, that would be really great. And as people are starting to respond to us today, and thank you for your responses, most of the people joining us today are from the public health sector. We also have people from the health sector other than public health joining us, research, provincial, territorial government and ministry, and someone from another sector. So thank you to all of you who have responded to that polling question. So just some few housekeeping items as we get started. So please either use the Q&A or the chat to post questions and comments during the webinar. And if you remember to just send the questions to all panelists, not privately to host, that'd be helpful, but if not, I will receive your questions and comments. And just to let you know that towards the conclusion of our webinar today, after the presentation by Dr. Hooper, we will have a session where she will take your questions and comments, and I will read those aloud to her. So please do feel free to not wait until that session to post questions and comments if they do come up during the webinar. And just in terms of technology, we recommend that you use a wired internet connection, and we've posted the helpline to WebEx should you experience any technical difficulties. And for those of you who may not have joined us previously, you will be able to listen to the audio through your speakers. So just go to Communicate and then Audio Connection. And again, these instructions are posted in the chat box. So we'd like to get a sense of how many people are joining us today, and one of the ways we've seen is that people are actually joining in groups these days, which is quite great to bring people together to hear about evidence. So as people are responding to the polling question, we do have the majority of people are joining just themselves, but we do have some groups of 2 or 3 people joining us today. So that's really wonderful. And again, thank you all for joining us and responding to our polling questions. So just would like to introduce to you our health evidence team, and really this just illustrates that there's many people involved on the health evidence team to keep health evidence current and maintained. So thank you to the health evidence team. And for those of you who may not be familiar with health evidence, it is a registry of systematic reviews about the effectiveness of public health and health promotion interventions. And being launched in 2005, we currently have over 4,600 quality-rated systematic reviews on our registry. And all of the systematic reviews in health evidence are rated for quality, and some do have summary statements available, such as the systematic review that we're going to be looking at today. And one of the main goals here at Health Evidence is to help to make evidence available about the effectiveness of public health interventions and to make it easier for those who would like to use this evidence in their decision making. So just as we move along, just a few, I would say, golden nuggets about health evidence. We try to save you time, again, by having a repository of a searchable database, freely searchable, of all the reviews on public health interventions. But we've also rated all of the reviews for quality, as I've mentioned. So hopefully we can save you time in your search and also in the critical appraisal piece. Again, our searches are regularly updated, so we hope to provide you with the most relevant and current evidence. We do use a transparent process for searching and for the critical appraisal, all of which the details are listed on our website. And we do also have some additional supports available under our tools section on health evidence of tools that you might use to think about how to help you use the evidence in practice. And we have found over the time that we've been in existence that those using our registry have found it quite easy to use. This is the model for evidence-informed decision-making, which some of you may or may not be familiar with. And what we find working with people in public health and outside of public health is that we're really good about considering most of the circles in this model, but one of the places that people find it a little more challenging is the research circle. And so what we've done here is to use this webinar series as a way to actually help identify the research evidence that would fall in that research evidence circle to help you better consider the research evidence along with all of the other components of that evidence-informed decision-making and making a decision. And these are just the steps within evidence-informed public health, so the steps to go about integrating that model. And what I would like to point out is that while there are 7 different steps, what we're going to hear about today from Dr. Hooper is how she and her team have worked through those first 4 steps in order to hopefully facilitate the whole process of evidence-informed decision-making or public health and using that evidence in practice. And just as we get started, so most systematic reviews are informed by a question, and that question is usually put into the PICO or PICO-S format. So just wondering as we get started and to help Dr. Hooper take things away today, just how many of you have heard of this acronym before? And we are seeing, thank you again for answering our polling question. Most people, probably 2/3, are familiar with the acronym, and there are some that are not familiar with this acronym. And just to give you an example of what the PICO format stands for, it's the Population Intervention Comparison Outcomes and Perhaps Setting, which Dr. Hooper will further illustrate for us as she talks about her and her team's systematic review today. So as we talk about using systematic review evidence in decision-making, and that's our hope here at Health Evidence, that we can help you use systematic review level evidence better. We'd like to know, how often do you use systematic reviews to inform a program or service in which you're involved in? And so most people providing the responses are saying often. We have a few saying always and a few saying sometimes. really encouraging that people are not answering a never, or I don't know what a systematic review is, so that's really encouraging to have people who are already using systematic reviews, even to a limited degree, joining us today. So thank you for your responses. So it's my pleasure to introduce Dr. Lee Hooper, who is a reader in research synthesis, nutrition, and hydration in the Norwich Medical School at the University of East Anglia, and has a BSc in biochemistry and a PhD and a current dietetic registration. She has worked as a dietitian in the National Health Service for over 10 years with extensive experience of community health promotion and cardiovascular health. Dr. Hooper moved to research in 2000 and has had numerous publications, mainly in the areas of dehydration and nutrition for older people and the effects of dietary change on health. With expertise in systematic reviews, Dr. Hooper is an editor for the Cochrane Heart Group for 14 years and was an editor for the Cochrane Oral Health Group. As well as being a Cochrane editor, she is a member of the World Health Organization Nutrition Guidance Expert Advisory Group on Diet and Health, which has recently produced guidance on sodium and potassium intakes. Dr. Hooper was a member of the National Institute for Clinical Excellence, or NICE, Partners Council, and is a current editor of the Quality in Aging and Older Adults, which was awarded the IBEX Award by the British Dietetic Association in 2005. So before I turn things over to Dr. Hooper, we'd like to see, and we're going to re-ask you this question at the end of the webinar again, so surprise, but we'd like to see what your sense is about, does reducing fat intake lower the risk of cardiovascular events? And so we do have a range of responses. Most people do agree, but we do have some people who are neutral and some who actually disagree. So it'll be really exciting to hear Dr. Hooper present the evidence and see if we, if your responses stay the same or change to the end of the webinar. So again, this is the review that Dr. Hooper will be speaking about today. And without further ado, I would like to pass the webinar on today to Dr. Hooper. So Dr. Hooper, I'm going to pass you the ball, and the floor is yours. Thank you for being here today.
Thank you very much. Hello, everybody, and thank you so much for joining us. I feel very honored to have so many of you from all across the world. That's lovely. Yeah, my name is Lee, and I worked on this review with several really great review team members. Nicole Martin is the managing editor of the Cochrane Heart Group based in London. Asma Abdelhamid is a doctor who was with us in UEA when we did the review. She's now moved down to London. And George Davies-Smith, who's a professor of epidemiology at the University of Bristol. A really great team. So yeah, it's down to all of us, this review. Now, I'm just trying to remember how to change the slide. Oh, yes, I do remember. Yeah, great. Okay. So what I was going to start with really was telling you a little bit about why we carried the review out. I started with a fairly neutral position on this. Some of you voted neutral. I think I was neutral at the beginning too. But I'm going to tell you a little bit of the history about why we carried it out. So public health dietary advice on the prevention of cardiovascular disease to do with diet has changed much over time. And during the 1960s, the focus was very much on fat modification. It changed in the 1990s and became all about fat reduction. So most of the guidance was about reducing fat to reduce our risk of cardiovascular disease. But it swung back again. So in 2006, for example, the American Heart Association suggested that people limit the intake of saturated fat to about 7% of energy, and the reason for that was to reduce the risk of cardiovascular events. And in 2013, they tightened that up a little bit more and said aim for a dietary pattern that achieves 5 to 6% of calories from saturated fat. And they reported that as strong evidence, and that strong evidence was based on randomized controlled trials, but randomized controlled trials with lipid endpoints rather than cardiovascular endpoints. And that's something that the US and the European guidance has in common, is that they're both based on dietary effects on lipid outcomes. One of the other things we need to remember with diet is that when we reduce one component of our diet, we will increase another. So our energy intake is likely to stay roughly the same. So if we're going to reduce saturated fat, we need to replace the energy from that saturated fat with something else. And we have various options. There are various other sorts of fats we could replace it with. We could replace with carbohydrate, we could replace with protein, we could replace with alcohol. So which nutrients are used to replace may affect our health just as much as the reduction of saturated fat in its own right. So, for example, a couple of guidelines from the UK recently have reflected that issue about what we replace saturated fat with. So there's the Joint British Societies in 2014 talked about replacing saturated fat with polyunsaturated fat. And our NICE guidance from the UK, that's the National Institute for Health and Care Excellence, which underpins the evidence in our National Health Service. They were looking at guidance for people at high risk of cardiovascular disease or with existing cardiovascular disease. And they suggested that saturated fats are 7% or less of total energy intake and replaced by mono or polyunsaturated fats. So the issue about replacement is coming up now, and I think that's one that we really need to be very aware of, really. The World Health Organization, the NUGAG subgroup, which sets dietary guidance on things like fats, but also sodium and potassium, as you've heard, wanted to understand a little bit more about fat so they could help set guidance in the future. So they were interested in the evidence of effects on mortality and cardiovascular health of reducing saturated fat. So not just looking at the lipid evidence, but looking at the evidence we have on hard outcomes. They were interested in how any effects differ depending on what type of energy is used to replace that saturated fat. And they're interested to know what sort of cutoff of saturated fats we ought to be recommending. Different groups, as you've seen with the different guidelines, have chosen different cutoff points. And they were interested to know what the evidence was underlying the cutoff point that they choose. So for this systematic review, we've carried out a systematic review of randomized controlled trials. I think the reasoning underpinning that is that there is huge amounts of confounding in terms of lifestyle. So if you look at how people eat, you can guess whether somebody smokes, how much activity how much physical activity they take, and what sort of socioeconomic status they hold by looking at their diet. It's not perfect as a measure, but there's a lot of coherence between those various different factors. So the difficulty with observational studies is how we tease out what effects are actually due to a particular dietary component from the effects we may be seeing in other dietary components in smoking, in physical activity, and socioeconomic status. So rather than getting involved in that tangle, which is a really important tangle, and lots of people do that really well, we wanted to have a look and see what the RCT evidence told us about the long-term effects of reducing saturated fat on cardiovascular outcomes. So that was the underpinning reason for the review and why it was carried out. This is the PICO question. We've just been talking about the PICO question. So this is our participants, intervention, comparison, and outcomes. And as Jenny said, the point of this PICO question is to be very specific about exactly what we're looking for, exactly what question we're asking. And when we know exactly what question we're asking, it makes it much more obvious what sort of studies truly answer that or answer that question well. So setting out this question quite clearly is a really important part. So we set our participants as adults. We were interested in any adults, whether they had a high risk of cardiovascular disease, whether they had existing cardiovascular disease, or whether they were at low risk, a population risk. Any of those were absolutely fine. We did, though, exclude people with acute illness and people who were pregnant or breastfeeding, simply because the effects are very slightly different in those groups. That was our participants. Anywhere in the world was fine. We were happy with anyone. In terms of the intervention, we wanted a study that assessed the effect of reducing saturated fat. So the intervention in any randomized controlled trial we were going to include in the review had to be to reduce saturated fat. But they could do that by giving dietary advice. They could do that by using supplementation. They could do that by providing a whole diet. But they had to do it for at least 2 years or 24 months to make sure that we had time to begin to see health outcomes accruing. So that was the intervention, reducing saturated fat, and we wanted that to be compared to people eating a fairly normal diet. So that could be a usual diet, or a standard American diet, or a standard European diet of some sort, or a placebo. So that's the comparison we were looking for, reduced fat compared to a normal fat diet. Reduced saturated fat compared to a normal fat diet, excuse me. And the outcomes, we have quite a long list of outcomes, but our primary outcomes were all-cause mortality, cardiovascular mortality, and cardiovascular events. The secondary outcomes are on this next slide. So we were looking at specific causes of cardiovascular events or deaths. So we were interested in the individual types of events that went in. So myocardial infarction, stroke, coronary heart disease mortality, coronary heart disease events added, type 2 diabetes, and blood measures, including serum bloods, lipids, and measures of glucose tolerance. And we were also interested in a variety of things that could be seen as adverse effects of reducing saturated fat. So we looked for cancer diagnosis, cancer deaths. We looked at body weight, body mass index, blood pressure outcomes, and quality of life. So a variety of things that might influence the decision that we might make to give or not to give advice to people around reducing their saturated fat intake. Now, to tell you a little bit, and the methods will be quite brief, but you're very welcome to ask about more detail about them if you're interested in this part. But we searched to March 2014. We used the Cochrane trial register central. We used Medline and we used Embase. We also looked through the biographies of all our included studies and also relevant reviews that we found. We sent the set of studies we knew about to a set of experts and asked if they knew of any other studies that we should be including. And altogether, I'll show you quite how we got to this in a minute, but altogether we assessed over 23,000 titles and abstracts, and we looked at 662 full-text papers. And what we found from that full set was 15 randomized controlled trials that did what we wanted. They reduced saturated fat, they compared that to a normal fat diet, and they did it for at least 24 months and measured at least one of our primary outcomes. So we've got 15 randomized controlled trials included in this review. This is the flow diagram. So when I say we looked through huge numbers, 23,000 titles and abstracts, we actually did some of that in the underpinning review. So we carried out a broader review a few years ago. It was published in 2012. And that review included 48 randomized controlled trials. They were slightly shorter, some of those randomized controls. They only needed to be at least 6 months long. And they did some slightly different things. So some of them simply reduced total fat. Some of them reduced saturated fat. Some of them did other changes in terms of dietary fats. All of them looked at the same primary outcomes we looked at. But of those 48 RCTs that were included in the previous review, 15 of them looked at saturated fat reduction and went on for at least 2 years. Unfortunately, when we ran our updated March 2014, although we looked through, again, a bunch of records, we looked through lots of full-text papers, and we wrote to the authors of 5 RCTs hoping they might have data that we could use, actually we could add no studies to our original set of 15. So what we have in this review is there's 15 RCTs, and they have 17 comparison arms. So sometimes, if you count up, you'll see slightly more than 15 in a forest plot. That'll be because we're looking at comparisons, like they've gone into the forest plot as comparisons. In terms of methodology through the review, we independently duplicated assessment of titles and abstracts, and also then of our full text papers that we retrieved. We duplicated data extraction, and we also duplicated assessment of the risk of bias of each of the studies. We contacted authors to request missing outcome data and also to ask about any risk of bias data that we didn't have. Those were the only 2 sorts of data we asked for, though. And then we tabulated the reasons for exclusion of excluded studies, and we also tabulated the characteristics of our included studies and the risk of bias of our included studies. And you'll see some of the bits from that later. Now, this is to tell you a little bit about risk of bias. What we used to assess risk of bias in our trials was the Cochrane risk of bias tool, which I think is a really clear and easy to use tool to assess the risk of bias in controlled trials. The elements of the Cochrane risk of bias tool, the elements of bias that you're looking at, are whether there was a random sequence generated, allocation concealment during that random sequence generation, blinding is really important, incomplete outcome data, so whether we lost people along the way and didn't find out what happened to them, and also selective reporting. That's the idea that you might have collected data on an outcome like MI or something else, but never reported it because you didn't quite like what it says or you didn't believe what it said. So those are elements of risk of bias that we took from the Cochrane risk of bias tool, and we assess them exactly as they assess in the current risk of bias tool. But we also added some elements that we thought were specifically interesting for our review. So we were quite interested in systematic differences in care. So if you think about it, a study that reduces saturated fat in one arm and has people eating normal fat in the other arm might well take the people in the low-fat arm and give them an evening lecture and seminar every 2 weeks for a couple of hours. It might then go out on a trip for shopping and see what sort of low-saturated fat foods you can find. It might go to a restaurant. And what those people get is quite a lot of social and quite a lot of health professional support. If the control group is not getting any of that, then when you see, or if you see a difference in health between the intervention and the control group, it's very difficult to know whether that's all because of the reduction in saturated fat, or maybe some of it or all of it is due to this difference in the kind of support that people are getting during the process of a study. So we were quite interested in looking at whether these studies had a systematic difference in care between the two arms. And the less difference in care there is between the two arms, the happier we are that any effects we see are due to the reduction in saturated fat. We also looked at whether the study stated in its aim to reduce saturated fat. That sounds idiotic, but actually we included studies that specifically said they were aiming to reduce saturated fat. And we also included studies that gave a more general aim. So some studies said, for example, their aim was to reduce cardiovascular disease. But when you looked at what they'd actually done in terms of dietary changes, it was clear that they were trying to reduce saturated fat. But they didn't explicitly say that. So we did actually include some studies that didn't specifically state their aim to reduce saturated fat, but what they were aiming at and what they did, clearly that's what they were trying to get to. We also included some studies that achieved saturated fat reduction and some that didn't do that. So some studies that stated they were aiming to reduce saturated fat didn't achieve a statistically significant reduction in saturated fat. And the other way around, some that didn't state an aim to reduce their saturated fat did achieve a significant saturated fat reduction. So we included both of those sorts of studies, but we were interested to see whether that mattered. And we also looked at whether studies had achieved serum cholesterol reduction, because that's a quite nice, if you like, slightly overview picture, maybe a slightly less biased outcome that would tell us something about whether saturated fat really was reduced. Rather than whether I, as a participant, might like you to think my saturated fat was reduced. So I might alter a little bit about what I say about what I'm eating. People do that sometimes, it's been known. Okay, so that's risk of bias. Those were the sorts of elements we were looking at about risk of bias, and you'll see how we use those a little bit further on in the talk. In terms of analysis, we used mental Heinzel random effects meta-analysis. We used the program RevMan5, which is freely downloadable from Cochrane. It's a lovely meta-analysis tool. It's a really, really good one. So we used mental Heinzel random effects meta-analysis to assess risk ratios. We assessed heterogeneity, and that's differences between studies, and to look and see whether the outcomes of the studies was very different study on study. We used I-squared to do that, and we were worried about heterogeneity when I-squared was greater than 50%. We extracted outcome data for the latest time point that we could within a study. So some studies were actually quite long, 7-8 years. But so we took the latest outcome data we could, but it was always at least 24 months from the starting point. We looked at the effects of saturated fat reduction and compared them to what happened in the control arm. And that sounds blatantly obvious, but sometimes studies don't do that. They compare saturated fat reduction to baseline, for example. And we used funnel plots to assess whether there was small study bias present. And again, I'll show you how we did that in a few minutes. Okay, we had pre-specified subgroups that we had specified in the protocol of the previous larger review. We were interested in looking at energy substitution for the saturated fat. So we were interested in whether it was monounsaturated fat, polyunsaturated fat, carbohydrate, protein. Actually, trans fat should be in there and alcohol should be in there. But we didn't find any data on either trans fat or alcohol, so they've been left off for the moment. But we actually did look for them. We were interested in subgrouping around baseline saturated fat intake, around sex, participants, baseline cardiovascular risk, and also study duration. And WHO requested, the WHO requested that we also look at degree of the saturated fat reduction, degree of serum total cholesterol reduction achieved, and ethnicity, all of which we did, of course. And we also carried out sensitivity analysis. And so sensitivity analysis, the purpose of them is to try out an analysis in a slightly different way to see whether your result is solid. If your result looks pretty much the same, regardless of which way you carry out the analysis, then you can be much more sure of it than if when you carry out sensitivity analysis, you get a very different answer. So the sorts of sensitivity analysis we carried out to just test it, just to see if we still got roughly the same answer, was we removed the studies that didn't state their aim to reduce saturated fat. Then we put them back in again, and we removed the studies that didn't report saturated fat intake during the trial, or if they did, they didn't see a significant reduction in saturated fat. Then we put those back in, and we looked at what happened if we took out the studies that didn't reduce total cholesterol statistically significantly. We put those back in, and then we took out the largest study, which was the Women's Health Initiative. Put that back in, and then we ran the analysis with two different sorts of analysis. So using Mental Hansel fixed effect model and then the Pito fixed effects model. So we ran the analysis in different ways just to see whether we still got the same result regardless of the way we ran it. And then we carried out a grade assessment, which is looking at the strength of evidence. It's something that the World Health Organization uses to understand how strong its evidence base is for things. So what sort of RCTs did we find? What have we got included? Well, just to tell you a little bit about them, of those 15 RCTs, we found that 6 of them were RCTs of people who actually had had a heart attack already or had angina. 4 of them were included people with diabetes or glucose intolerance. 3 of them included people with a cancer risk or a diagnosis of cancer, but in the past, so not an acute diagnosis. And 2 of them included people with no specific risk, so a general population type group. So that's quite nicely spread over different levels of risk of cardiovascular disease at baseline. We also looked at geography, and what you see is 6 of the 15 came from North America, 7 came from Europe, and 2 came from Australia and New Zealand. That's nicely spread, but what we were really sorry not to see was any studies from developing nations. That would have been really helpful and helped just give a different perspective on the data, but we didn't find that, unfortunately. Okay, enough about methods. I hope I haven't put you all to sleep on that one. What I want to talk about then, first of all, is the results on the effect of saturated fat on all-cause mortality. Okay, so what we're looking at, as I say, is the reduction of saturated fat, the effect of that reduction on all-cause mortality. And this is the key forest plot. So this is basically giving you the answer. What you're seeing in this forest plot, I don't know if many of you are used to seeing forest plots, so I'm going to describe it for you a little bit first of all. What you're getting is rows of data. And so what you see is that each study has its own row. And for each study, you have information on the number of events, and that's deaths in this case, in the reduced saturated fat group, and the total number of people in the reduced saturated fat group. And then we have the number of events and the number of people in the usual diet group. So that tells us, for example, if you look at the very first study in the row, Black 1994, had 133 participants, and they had 3 deaths altogether. Okay, so that's a fairly small study, fairly small number of deaths adding up, but it's one of the studies that fitted the criterion. It went on for at least 2 years. It reduced saturated fat in one arm and had normal fat in the other arm. So we've used that data with the data from all the other studies that have gone into this graph. For Black, what you see is that the risk ratio was 0.51. So what you're seeing is very, very wide confidence intervals on that risk ratio, but you're also seeing the suggestion of roughly halving the risk of death if you reduce your saturated fat intake. But that's, of course, on very, very small amounts of data. Okay, that risk ratio of 0.5 is plotted in the graphy bit in the middle. And then to the right of that, what you're seeing is our risk of bias assessment for that study. And what you can see is that it did very well. It has a green blob for random sequence generation, so that's good. That's low risk of bias. It has a query, an orange blob, for allocation concealment. So we're not so sure about allocation concealment. They didn't tell us enough about the methodology of the study that we could judge it. And for blinding, it has a red spot, which means that's high risk of bias. And that's really common. If you look down C, which talks about blinding, you'll see that most studies were at high risk of bias from blinding. And that's because these are dietary studies. It's really, really difficult when you're getting people eating for long periods of time that they don't know whether they're on a low saturated fat diet or not. It's very, very difficult. The one study that did it well, if you look down, is the Veterans Admin study. It has a green blob on column C. And they did that by, it's an institutional study. So it was the Veterans Admin Residential Centre, and they randomised people to do different sorts of meals and kept them quite well blinded, as we understand it. Okay, so that's the blobs on the right-hand side are telling you something about risk of bias. If you come down the forest plot, there's a line that says total, and then brackets 95% confidence interval in bold. And that line tells us quite a lot of information. It tells us that we've got over 22,000 people in the reduced saturated fat arms, and we've got over 33,000 people in the usual diet arms. We've then got a risk ratio, and that's our pooled risk ratio. This is the answer, if you like. Our pooled risk ratio is 0.97, with confidence intervals that run from 0.90 through to 1.05. Now, a risk ratio of 1 would mean that exactly the same number of deaths happened in the intervention, the low saturated fat group, than happened in the usual fat group. Okay? So a risk ratio of 1 means there is no effect of reducing saturated fat on all-cause mortality. What we're seeing here is a number very close to 1 and not statistically significantly different from 1. So what this is actually telling us, putting all this data together, and we've got over 3,000 deaths plotted in here, from over 55,000 people overall who were involved in studies for at least 24 months. From all that data, it's telling us quite clearly that there's very little effect of reducing saturated fat on all-cause mortality. The I-squared number, which you'll see both as part of the forest plot, and also I've added it in the bottom right-hand corner just to be really clear about what I-squared is. It's in among lots of other numbers within the forest plot itself. I-squared is 3%, and that suggests that the studies are very, very similar in telling us that there's no effect. Okay? Some studies are not telling us, yeah, there's a huge effect, and other studies saying there's nothing happening, or there's an increase in risk. The studies are actually telling us very similar things, all those studies in this forest plot. Okay, so I won't describe all the forest plots in that detail. I hope you don't mind me going through a little bit on this one. I hope that makes some sense of what you're seeing for this forest plot. So this is really clear data saying there's very little evidence that there's any effect of reducing saturated fat on all-cause mortality. This is the funnel plot for the same forest plot you just saw, the same data you just saw. What you like to see in a funnel plot, and again I can explain this in more detail if anybody wants to talk about it later, but what you like to see in a funnel plot is an inverted V, a perfect mountain if you like. What we're seeing here is very close to an inverted V. There's no suggestion to think that it's not an inverted V. If we were missing the green blocky studies on the left-hand side of the blue dotted line, we wouldn't be seeing an inverted V. We'd be seeing something that was quite skewed. That would tell us that there's some missing studies, that there's studies that have been carried out and we haven't got the data. It's very likely there's missing data, and therefore our data, the answer that we have got may well be skewed. Here, what we're seeing is pretty evenly distributed, a nice inverted V. As far as we can tell, that looks like we've not got an obvious problem with studies missing. So we've not got an obvious problem with publication bias here. Okay. As I said, we were interested not just in what the effect of reducing saturated fat, which you've just seen the forest plot for, but what happened if you replaced that saturated fat by polyunsaturated fat, or if you replaced it by mono, or carbohydrate, or protein, or trans, and actually alcohol was in there as well. So we've actually characterized the studies by what the replacement was. And so this is very much the forest plot you just saw, but it's split into subgroupings. And those subgroupings are for the different replacements. So the first top subgroup says replaced by PUFA. That subgroup is a subgroup where saturated fat was reduced and at least some of the replacement was polyunsaturated fat. what we see in that group, where the replacement was polyunsaturated fat, is a relative risk of 0.96, again with wide confidence intervals. The same is true if you look at replaced by carbohydrate, that's the third group down, CHO, relative risk of 0.98, very wide confidence intervals. If you look at replaced by protein, relative risk 0.98, very wide confidence intervals. So those three groups are all telling us that we've got some evidence, again, that there's not much effect of reducing saturated fat and replacing it by any of those three things on all-cause mortality. The MUFA line is slightly odd, or the MUFA section is slightly odd, because we have very, very small amounts of data in that section. There is one study, in fact, there's one study arm. We've got the olive oil arm of the ROSE trial. That section of study only had 52 participants and only had 4 deaths. So we've got very, very minimal data for monounsaturated fat replacement. So while we've got a relative risk of 3, which suggests, in fact, increased deaths if you reduce saturated fat and replace by monounsaturated fat, the confidence intervals of that are, again, enormously wide. And that's because we've only got those 4 deaths. We really don't have enough data to understand what's going on in that group, unfortunately. So what this is telling us is, regardless of what we replace our saturated fat by, there's no clear suggestion that any of those have a brilliant effect on our all-cause mortality. We also, as I said, carried out sensitivity analysis, but none of the sensitivity analysis altered our risk ratio. All of them were from between 0.96 and 0.99, and none of them altered the lack of statistical significance of the effect. So really, whichever way we carried out our analysis, we would have got roughly the same answer as we've got from the analysis we actually did carry out. And again, no subgrouping that we carried out altered the verdict that there was no effect for all-cause mortality. So we looked at longer and shorter trials, and again, they all showed roughly the same effect. Okay, nothing much going on here. Okay, so very clear, not much happening with reduction of saturated fat as regards all-cause mortality. However we looked at it, we couldn't see an effect, so we don't think there is one there. What about the effect of saturated fat reduction on cardiovascular mortality specifically? Okay, so I'm going to show you the evidence for this now. Right, again, this is the key forest plot for cardiovascular mortality. Very slightly different set of studies because we didn't get data on all-cause mortality on every study. We didn't get data on cardiovascular mortality on every study. So the studies are put in when we have the correct data for them. So what you're seeing here, I'm going to skip going through each of the individual studies. If you look at the total line, the bold line, total 95% confidence interval line, what you're seeing is that we had over 1,000 cardiovascular deaths represented in this forest plot. We had over 53,000 participants represented in this forest plot. And the overall effect was a risk ratio of 0.95, again with wide confidence intervals, running from 0.8 up to 1.12. So we've got no statistically significant effect of reducing saturated fat on cardiovascular mortality. I-squared is still well below 50%. It's a little bit higher this time. It's up at 30%. But again, that's quite a lot of coherence. The studies are pretty coherent in telling us there's not much effect of reducing saturated fat on cardiovascular mortality. The funnel plot, again, we're looking for that inverted V. That looks pretty sound. Doesn't look like much of a problem with that funnel plot. So it doesn't look as though there's major studies missing. What about if we look at the replacement? So we're reducing saturated fat, replacing by PUFA. Well, what the suggestion here is that the risk ratio, if we replace by PUFA, is 0.95. Again, wide confidence intervals. If we replace by carbohydrate, the risk ratio is 0.99, even closer to 1, again with wide confidence intervals. And if we replace by protein, even closer, still close to 1, 0.99 still, wide confidence intervals. So again, no suggestion that any of these subgroups are we seeing a sudden reduction in cardiovascular mortality due to reduction in saturated fat and replacement. Again, the data with replacement for monounsaturated fat is very, very scarce. We've got the same little study arm with 52 people in it, only 4 deaths, and these were all cardiovascular deaths, interestingly. Exactly the same set of data we saw in all-cause mortality. Not enough data to understand really what the effect of replacing with monounsaturated fats might be, sadly. So again, no sensitivity analysis altered the altered the effect size. So all of the risk ratios ran from 0.92 up to 1, and none of them altered the lack of statistical significance. And we didn't find any subgrouping that altered the verdict of no effect for cardiovascular mortality, except there was a suggestion that with greater reduction in saturated fat, we might see a slight reduction in cardiovascular mortality. And that came just from one study. It was the Veterans Admin study, which I pointed out earlier simply because it was a study that happened in an institution, therefore they were quite well controlled with their diets. And what they found in that study was they had a big reduction in saturated fat because it was very controlled, and they found a risk ratio of 0.7, which is a 30% reduction in cardiovascular deaths with a statistically significant confidence interval, so running from 0.51 up to 0.96. So there was a suggestion in that one study which had greater saturated fat reduction, but we didn't see that effect in any of the other groups at all, or any of the other subgroupings at all. Okay, so very, very limited evidence of any effect at all on cardiovascular mortality of reducing saturated fat. So we're going to go on now to looking at the effect of reducing saturated fat on cardiovascular events. And this is a composite outcome. So what we did was we put together where we could data on cardiovascular death, cardiovascular morbidity, which includes non-fatal MI, angina, stroke, heart failure, peripheral vascular events, and atrial fibrillation, and also any unplanned cardiovascular interventions. Now this combining outcomes was done very carefully. We weren't looking for numbers of outcomes, we were looking for number of people with outcomes. So you have to be quite careful with how you combine your data. Because if there was somebody in a study that had angina and then later died, a cardiovascular death, we wanted to count them once, not twice. So it's the correct statistical way is to count a person. A person is randomized in, you look and see whether that person suffers an event or doesn't suffer an event. And more than one event still just counts as one. Okay, so that's cardiovascular events. We're looking for any of those outcomes in people. That means we've got slightly more events to play with, which is helpful, although we couldn't get data from all of our studies. Okay, so what do we see here? This is a forest plot. Again, we look at the total line down at the bottom. We're looking at over 4,000 events, cardiovascular events happening in our population, over 53,000 participants involved in studies for at least 2 years. What we're getting now is a risk ratio of 0.83. And this is a statistically significant risk ratio because the confidence interval is all below 1. So all of the possible or the likely outcomes are below 1, which suggests a reduction in risk of cardiovascular events. So the overall best estimate you'd give here is to say that, okay, if you reduce saturated fat, we reduce cardiovascular events by about 17%. But that could run from about 28% with a risk ratio of 0.72 up to a reduction of about 4%. I-squared is no longer quite so low. We've got it's crept up now to 65%, which suggests that some of the studies are telling us slightly different effect sizes than other studies. So we need to look at that heterogeneity and understand why some studies are saying the effect is greater than other studies. But we'll have a look at that in the subgrouping. So this is the first of the primary outcomes. In fact, it's the only primary outcome where we see a statistically significant effect. If we look at the funnel plot, it's quite difficult to interpret. That's not a funnel plot that, and I've taken this to people blind, by the way, so the trouble is with doing a review, you have some opinion of what you think the data are like. So I've given this forest plot to several statisticians without them knowing what the topic was and said, would you say that's a biased funnel plot? Basically they're saying, it's difficult to tell that one. So it's really hard to know. You can't say, yes, there's a problem with publication bias here. You can't say there isn't either. But basically the overall opinion was that that's not a funnel plot that you'd worry about. So as far as we're aware, we haven't got seriously missing data here. What about the replacement then? So what happens when we reduce saturated fat and replace it by polyunsaturated fat? This is the first subgrouping at the top here. This is interesting. What we see here is a relative risk of 0.73. So the overall, for the overall whole group, we were seeing a risk ratio of 0.83. It's now dropped to 0.73. So it's a 27% reduction in cardiovascular events now. Again, statistically significant. We've only got 884 events, but we only got just over 3,000 participants, but we're seeing a clear statistically significant effect. With MUFA replacement, we have the same problem we've seen before, the same very small study, very small amounts of data, but no suggestion of an improvement of cardiovascular events, but we wouldn't see it even if it was there with this much data. The suggestion for both replacement by carbohydrate and replacement by protein is no effect. We're getting a risk ratio of 0.93, not statistically significant, a risk ratio of 0.98, not statistically significant. So it looks as though where we're getting effects on cardiovascular events, that's coming from where we're reducing saturated fat and replacing by polyunsaturated fat. We may be getting some benefit from replacement by MUFA, but we can't see that in this data. And this is just showing you the set of sensitivity analysis. I've gone over them relatively quickly before. I'm showing you just a little bit more detail here. So I'm showing you each of the sensitivity analyses in turn. And what you see is the main set of data in the top row, and then I've shown you each of the sensitivity analyses in the rows before. And the statistical significance is maintained in all of the sensitivity analysis, bar one. So in the saturated fat significantly reduced category, we lose statistical significance. Only barely, but we do lose it. All of the others are clearly statistically significant. And the risk ratio alters a little bit, alters from 0.83 in our overall analysis, all the way up to 0.93, all the way down to 0.75. But overall, we're not seeing a dramatic difference. We're seeing a suggestion that actually when you reduce saturated fat, you do reduce cardiovascular events. And this is subgrouping data. Now, you won't have long enough to absorb all of this, and I apologize. You're welcome to look at the slides again later and get a bit more detail from them. The first subgrouping is the replacement subgrouping that I've already shown you in some detail. So that's showing you the same thing again. But we've also done subgrouping by duration. That's duration in study, subgrouping by the baseline saturated fat intake, subgrouping by saturated fat change. And where you see that there's an effect is around subgrouping by saturated fat change. So what you see is there's very little effect when we're reducing saturated fat only up to 4% of energy. Very little effect on cardiovascular events, but the effect seems to be cutting in when we're getting better than 4% reduction in saturated fat. That's when we start to see reductions in cardiovascular events. Not anything very exciting happening with subgroups by sex. We can talk about that if you'd like to. It's not particularly coherent data. There's no suggestion really of anything very different happening by cardiovascular risk. What you do see is that when you only reduce total cholesterol a little bit, you see no effect on cardiovascular events, but when you reduce total cholesterol a bit more than 0.2 millimoles per litre, you start to see effects on cardiovascular events. They start to fall. Okay, so just to summarize that, what we're seeing with the sensitivity analysis is fairly consistent reduction in cardiovascular events with reduced saturated fat for almost all sensitivity analysis. And with subgrouping, we would say that subgrouping explains some of the heterogeneity, some of the different effect sizes we're seeing in different studies. So that greater reduction in cardiovascular events happens with greater saturated fat reduction and with greater serum total cholesterol reduction. And partly as well, we're seeing that happening with where saturated fat is replaced by polyunsaturated fat. We also ran a meta-regression. This was it was planned in. It was in the protocol. We ran meta-regressions in the original review, and we reran them for the update. So we were interested to look and see what sort of individual factors had an effect on cardiovascular events when we put them all in together. And what we found was that greater reduction in serum total cholesterol was associated with greater improvements in cardiovascular events, as you'd expect if this is actually a true effect. And that accounts for a great deal of between-study variation. So actually the amount of cholesterol reduction, total cholesterol reduction we get very much accounts for the differences between the studies. And you see that also reflected in that greater reductions in saturated fat intake or greater baseline saturated fat intake were loosely associated with a reduction in cardiovascular events. Gender, study duration, baseline cardiovascular risk didn't really appear to influence effect size.
Dr. Hooper, it's Jenny
Yes.
Yost here. Just wanted to let you know that we've only have about 5 minutes or so left in our
Okay,
hour.
that's fine. I'll finish up in 5 minutes. No problem.
No, so I
Thank
just
you.
wanted to let you know.
Yeah, no problem. I'll keep going. Sorry, if that's okay. Okay, so yeah, this is just to show you very quickly the effects on serum cholesterol in the different studies. And what you see is different studies had different amounts of serum cholesterol reduction. The pooled overall effect was about 0.24 millimoles per litre, and that's equivalent to about 9.3 milligrams per deciliter if you use that form of measuring. Okay, secondary outcomes. I'm going to go very quickly through this. Roughly what we saw was a marginally significant effect of reduction in MI with reduction in saturated fat intake, but we didn't see effects on stroke, cancer deaths, cancer diagnoses, diabetes diagnoses, coronary heart disease mortality, or coronary heart disease events, although coronary heart disease events was a little bit closer to the line. We also did something about testing cutoffs for saturated fat intake for WHO, and since we're short of time, I'm not going to go into that. I don't think it's hugely interesting. It's very weak evidence for looking at how you might set a cutoff for saturated fat intake. So I'm not going to go into that. If anyone's interested, I'm very happy to talk about it. What I'm going to go on to is just answering the very specific WHO questions that they were interested in asking, just to go through how the evidence stacks up, if you like. So they asked in adults, what's the effect in the population of reducing the percentage of energy intake from saturated fat relative to higher intake for reduction in risk of non-communicable diseases? And we've said we see clear reductions in cardiovascular events, marginally statistically significant reductions in myocardial infarction, but no clear effects on all-cause mortality, cardiovascular mortality, stroke, CHD mortality, CHD events. They asked, what is the effect on coronary heart disease mortality and coronary heart disease events? We said there are no clear effects of saturated fat reduction on CHD mortality or CHD events, but the evidence is limited here. And they asked what's the effect in the population of replacing saturated fat with PUFAs, MUFAs, carbohydrate, and they asked about refined and unrefined. We didn't have any data on that at all. Protein or trans fatty acids relative to no replacement for reduction in risk of NCDs. So saturated fat replacement with PUFA seems to be associated with reductions in cardiovascular events and in marginal significance for reduced MI. Replacement with carbohydrate and protein are associated with no clear effects on outcomes. We didn't have any trans fat data available, and we've got very limited MUFA data. And what's the effect in the population of consuming less than 10% of energy from saturated fat compared to eating more than 10% of energy as saturated fat? And again, we've said that's limited RCT evidence, but what evidence there is supports better health at less than 10% of energy from saturated fat. But that's a very weak result from our systematic review. And this is the grade table. So the grade table is looking at the quality of evidence overall. And what we've got here is that the evidence on all-cause mortality is high-quality evidence. High-quality evidence saying that there's no effect of reducing saturated fat on all-cause mortality. We've got high-quality evidence that there's no effect of reducing saturated fat on cardiovascular mortality. And we've got moderate evidence for saying that there's a benefit if we reduce saturated fat, particularly if we replace with polyunsaturated on cardiovascular events. So that's the overall evidence from our review as the WHO see it. And I think that's a reasonable summary of it, to be perfectly honest. Any questions?
Thank you so much, Dr. Hooper. So we have a few moments for a question or two here. And we do have a question from Mark Andrew. And he would like to know, how do you explain that there are fewer cardiovascular outcomes, but not fewer cardiovascular deaths, nor all-cause deaths?
So is he asking about the number of events represented in the forest plots? Is that what he's asking about?
I'm not exactly sure. So, Mark Andrew, if you wouldn't mind just maybe posting in the Q&A or the chat your response to Dr. Hooper's question.
Shall I answer what I think he's asking? And if that's not right, he's very welcome to either email me or repeat ask. But I think what he's asking is why we're not seeing the appropriate ratio of overall deaths, cardiovascular deaths, and cardiovascular events. What we'd expect to see is relatively more cardiovascular events than we see cardiovascular deaths. And what the problem is how you get hold of the data. So it's not so much how many cardiovascular events happened, it's how many cardiovascular events you're able to actually combine together, being sure that you're not counting any one person twice. So some of the data we have we can't actually add in because it may be additional events to the same people, and we can't tell that. So we can only use data we're sure about, so we've only been able to use a proportion of the data that exists because people can't provide us the data in the way we need it sometimes. Does that help a little bit?
Thank you, Dr. Burr. And Mark Andrew, let us know if that has answered your question or not. And there was one other question that someone posted referring to the risk of bias tables. It appeared that there were 2 studies for which there was no risk of bias indicated. So someone was just wondering if you might be able to explain that.
The reason for that is there were 15 studies and 17 arms of studies. And what we didn't want to do was put, where there were 2 arms of a study, we didn't want to score that study twice because it made the effects of that study more important. So where there was an additional arm, where there were 2 arms in a study, we only scored one of those arms. So there are 2 blank rows. That's why.
Great. Thank you so much, Dr. Hooper. And as we wait to see if anyone has any further questions, I'll just move on to the conclusion of our webinar, but please continue to post any questions in the chat or Q&A for Dr. Hooper, as we do have a few more moments left this afternoon or this morning, depending on where you're joining from. So we would like to know, asking you again this question, does reducing saturated fat intake lower the risk of cardiovascular events? So we would like to get your opinion on this now after hearing the evidence from our expert today. So we are seeing that people are answering strongly agree and neutral. A few disagrees, but the majority of people answering our polling question today are saying that either strongly agree or agree. And then just alongside of that, do you agree with the findings of the review that Dr. Hooper has presented today? And as people are answering that polling question, Dr. Hooper, we have had another question come in from Matilda, and she would like to know what kind of CHO were used to replace SFA overall in the included RCTs?
We wanted to know more about that. We looked really hard to find out because we were interested in the difference between refined and unrefined carbohydrates. And we thought there may be different effects between refined and unrefined carbohydrates. But unfortunately, virtually none of the studies told us anything useful on that score. So all we got from most studies, if indeed we got that much, was an assessment of the amount of carbohydrate taken in the intervention group at a particular time during the study and the amount taken in the control group. And we never had it separated into simple sugars or non-milk extrinsic sugars or anything like that. So we have very, very little information about that. And it's very frustrating. And that's one of the problems with randomized controlled trials, is you can't go back and re-find that out. The data's gone now. So we don't know. We'd love to have found out more.
Great. Thank you so much, Dr. Hooper. And just to let everyone know of the results of our polling questions, that most people either agreed or were neutral when providing responses. So thank you so much for that. And we have had another question, Dr. Hooper, from Becky. What was a sensitivity analysis conducted to compare results from RCTs from the general population versus those studies using samples with comorbid conditions for all outcomes that you explained?
Yes, we did that for all of the primary outcomes, all 3 primary outcomes. We didn't do it for all of the secondary outcomes. And the reason for that is you end up doing a huge number of analyses. The problem with doing lots and lots and lots of analyses is that you can get spurious statistical significance after a while. You've done so many analyses. We've done a lot anyway, but you get so many analyses that you eventually have to get lots of statistical significance, bouncing up in places that you wouldn't expect and aren't really very, very useful. So we did the sensitivity analysis and we did the subgrouping really carefully with our primary outcomes. We did a couple of bits of subgrouping for a couple of the secondary outcomes, things like MI, because we were asked to by WHO. But we did that very, very carefully, and primarily we were doing it with our primary outcomes.
Great. Thank you so much, Dr. Hooper. And we'll just wait to see if any further questions come in. And I would just, bringing us back to the model for evidence-informed decision-making, I think it's really wonderful. And thank you, Dr. Hooper, for presenting on the research evidence today. And again, trying to help fill the gap or try and help us consider that research evidence in making our decisions with all the other sources of evidence that we do consider. And
You're
so
welcome.
Just,
Thank you all for listening. That was very, very kind of you.
And so we're just wondering get a sense of how useful the webinar and the information was today to all of you. And we have had another question come through, Dr. Hooper.
Yep.
And Matilda was wondering, when looking at all of the studies and the risk of bias that was presented towards the beginning of the webinar, is there one that you would consider most critical as a risk of bias?
One of the factors. Allocation concealment is quite an important one. We've got quite good evidence that where a study doesn't have good allocation concealment, that the effect size tends to be larger. So allocation concealment is probably one I would think is a really critical issue. The relevance of blinding is quite a difficult one to work out. We really like to see blinding when we've got drug trials and we've got all sorts of other studies. We really like to see good blinding. We just can't get it in dietary trials. And the effect of that on our belief in the answer is a really interesting question. Because we can't get it doesn't mean we should disregard it, but because it potentially is biasing things a little bit. So if I know I'm on a low-fat diet or a low-saturated fat diet, I may not worry so much about my smoking, because I think my risk of cardiovascular disease is being dealt with. Whereas if I know I'm on the normal, usual diet, I may think, oh gosh, well, my risk of cardiovascular disease is still quite high, maybe I should think about dealing with my smoking. You don't know what other effects it's going to have to know which arm you're in. So it's a very good question. We don't have very good evidence for most of the categories, but we do have good evidence that if we haven't got good allocation concealment, and that's about whether you know which arm somebody knows which arm you're going into when they recruit you into a study, that does have an effect on studies' effect size. So that's the one I would probably look at most critically in terms of thinking about which of the studies are better studies.
Great, thank you. And just moving on towards the conclusion today, so we've listed a few things here that you might think about possibly doing, checking more into health evidence, in addition to looking at the review in further details that Dr. Hooper has presented today. So as we have one last polling question for you about next steps, we do have one last question that I think we might have time to field, if that's okay with everyone. And so the one last question was from Becky, Dr. Hooper, and she was wondering to explain some of your non-significant findings for the primary outcomes. Yep. Do you think the interventions were simply less effective in community settings versus institutions?
It's difficult. I guess I believe that if we can have enough effect on cardiovascular events over a long enough period, it eventually will have to affect cardiovascular mortality. The complication with that, of course, these days is that most of the people who have cardiovascular events survive them, which is great. That's a really, really wonderful thing. So it's brilliant that they do. So I guess I kind of believe if we had evidence over a longer period of time that we probably eventually would see an effect creeping in on cardiovascular mortality. And if you have enough evidence on that, eventually you'll see data on overall mortality. Eventually it will dent it. But I think it just is quite a small effect, so that although we can say, yes, we've got effects on cardiovascular events, which is brilliant, there just isn't enough of an effect on cardiovascular mortality, all-cause mortality, for us to actually see it in the statistics. And that suggests that it's not a big enough effect to worry about enormously. You know, me as an individual, whether I'm actually going to change my diet to reduce saturated fat, the effect on my mortality is going to be relatively small. So that's not the reason I'm going to do it. Even if there is an effect there and it's statistically significant eventually, that's not going to be the reason I change my diet. So I think I might want to change my diet because I find it important that I reduce my risk of cardiovascular events, and I think that's a jolly good reason. And I think in the public health context, we can make the argument that it is worth doing to reduce cardiovascular events because they have costs associated with them, both personal costs but also healthcare costs. But I don't think I would make the argument that we should be doing it to reduce all-cause mortality. I don't think that makes sense. I don't think there's good enough evidence for that. I'm not sure it's about institutional setting. If it is to do with institutional setting, it's simply that they're able in an institution to implement the intervention better than I might be able to in my own home over a couple of years. So maybe we're just getting a truer implementation of the intervention in that institutional study, for example, the Veterans Admin study.
Great. Thank you so much, Dr. Hooper. And thank you, everyone, for joining today and for all of your wonderful questions and comments. And I would just like to conclude by saying just a reminder that the presentation will be available along with the slides on our SlideShare and YouTube accounts. And I will just leave the last word to you, Dr. Hooper. So any last words of wisdom or any other thoughts that you'd like to leave the group with us today?
Sure, thank you. Thanks for sticking with me. And I think what's interesting about carrying out systematic reviews is you don't always get the answers that you expect. I would have expected when I started to see effects on mortality and cardiovascular mortality, and I was surprised not to. But that doesn't mean that that's the fact that I expected to see it doesn't mean I should have seen it. Maybe it really, really isn't there. It's a small effect.
Thank you so much, Dr. Hooper, for being with us today and giving up so much of your valuable time. And thank you to all of the participants. And we hope to see you at future webinars and cross paths in the future. So thank you, everyone, and have a lovely rest of the day.